The first aspect, thank you, Dr. Lekan, for sharing this thing, is on pacemaker again. This is an area I don't know so much, and I would welcome comments as we discuss this aspect. But I'm going to try to just say the things I know, and I know that when we have the session with Prof, he will clarify a number of these things. So from 411 to 414. Question reads, for each clinical condition, match the most appropriate pacemaker mode. So we are to match the appropriate pacemaker mode for each of them. A, VAT, and B, VVIR, C, DDD, D, DDR, and E, AAIR. And then there are questions under that, but maybe as a way of opening the discussion, to just mention that there are many ways to actually give nomenclature to pacemakers, their coding. However, the commonest one that is used is the one that involves 4-letter code. And the 4-letter codes actually have various have meanings. And it means that for the positions, they have various meanings. So the 4-letter code, for example, if you have OAVD, the first position is implying the chamber that it is being paced, while the second position is the chamber that is being sensed. Then the third position is referring to the response to the sensing. And response to sensing could be that there could be no response, or it could be triggered, or it could be inhibited. While the fourth position is the programmability or the rate modulation. And in rate modulation, you can have either a non-response or a rate modulation. The aspect of the rate modulation is actually important, as we will see, especially when we're talking about chronotropic incompetence. So that aspect is actually very, very important because it has the capacity, to independently, continue the pacing irrespective of intrinsic cardiac activity. And it does that by just monitoring the physiologic processes of the body. Sorry, hope am I still being heard?
Yes, you are audible, sir.
Thank you.
Yes, thank you.
Okay, so let me start with an example here, or let's just read on the whole case presentation. The first one is for 411, a 58-year-old man with tachybradycardia syndrome who develops symptomatic sinus bradycardia. He has tachybrady syndrome and develops symptomatic sinus bradycardia. Now, there are a few things to remember in terms of selection of appropriate mode for cardiac pacing. And the three major things to look out for is one, what is the underlying reading disturbance? And then number two is to look at what is the patient's level or the exercise capacity of the patient, and then the chronotropic response to exercise. For example, if we say VVI, what we mean is that the ventricle is being paced, the ventricle is being sensed, and then the response to the sensing is actually an inhibition. So it means that the VVI means that the ventricular pacemaker output is inhibited if a ventricular event is sensed. That's the native event or the cardiac event. If it is sensed, the pacemaker output will be inhibited. Okay. And then in patients that have chronotropic incompetence, which means they are unable to achieve or have a commensurate increase in their heart rate or in their cardiac response due to level of exertion or level of activity, you now need a rate modulation, to act add to them. Then generally, we know that they can be either a single chamber pacing or dual chamber pacing. Currently, we favor more of dual chamber pacing, but it actually depends, like I said, on what the underlying reading disturbance is and other factors for patients. So I'll now go on to discuss each of the areas. 411 says a 58-year-old man with tachybrady syndrome who develops symptomatic sinus bradycardia with beta blocker therapy. Now, if we look at this patient, we are to choose which of the pacemaker mode will be preferred or will be appropriate. For this 58-year-old man, we'll see that he has tachybrady syndrome, which already means that he has a sinus node dysfunction. And because he has a sinus node dysfunction, that is already a clear indication for a pacemaker. But the other aspect to this patient is that he's on a beta blocker. And because he's on a beta blocker, he's at also a risk, of having an atrioventricular block due to the beta blocker. So in this type of patient that has a sinus node dysfunction, already having a risk for an atrioventricular block, you will need a dual chamber pacemaker that also has a capacity for a rate modulation in the patient. So looking at the options, the most appropriate to use in this type of patient is the DDDR, where the DDD all stands for dual chamber pacing, dual sensing, and then the third position, which is the third D, stands for it can either trigger or inhibit, and then there's a rate modulation because of the risk of an atrioventricular block. So the answer to 411 will be option D. Thank you. I don't know if there's any question or comments in addition to that. Okay, there's none. 412 talks about a 70-year-old woman with long-standing atrial fibrillation who complains of dizziness and is found on examination to have a ventricular rate of 30 beats per minute. So in this patient already symptomatic with atrial fibrillation, and the ventricular rate is now found to be 30 beats per minute. So you see that in this patient, because there's already an established AF, atrial sensing or atrial pacing will not be very important or appropriate for this patient. And it is usually not possible when in the setting of an atrial fibrillation. So the rate modulation is also necessary in this patient because we can see that the patient is already symptomatic and the ventricular rate is already 30 beats per minute. So looking at the available options for this patient, the patient will need a pacemaker that is that can pace the ventricles, that can sense the ventricles, and then can inhibit if there's intrinsic activity. But the patient would also need a rate modulation. And like we said earlier on, rate modulation simply means that the pacemaker will have an intrinsic ability or capacity to be able to, pace irrespective of what the cardiac activity is. And this is important because in this person, we're already saying that ventricular rate is as low as 30 beats per minute. So if we are to choose for this 70-year-old, the best option to choose will be option B. The reason being that we need a pacemaker that will pace sense. The major issue is with the ventricles. There's already an atrial fibrillation, so the atrial sensing or pacing will not be possible for the atrium. So the focus will be more on the ventricles for the pacemaker, and then it should have an ability to moderate or an ability to modulate the rates for the patient. Thank you. I hope it's not sounding like Greek. All right, any comment, please, or input? Please, do I go on?
Please continue, sir.
Okay. Thank you. Then question 413, it's on a 62-year-old man with complete heart block after aortic valve surgery. The complete heart block is an indication for pacemaker. So we are looking at what kind of mode would this type of patient, need. Please, can you go back to the option? So will it be a VAT, VVIR, DDD, or DDDR? For this patient that already has a complete heart block, what the patient will need will be a pacemaker, that is dual chamber, okay, that can pace, that can sense, and then inhibit or do tracking, as well. And that will be the preferred pacemaker for this type of patient. Now, the pacemaker with rate modulation may not come in here because we do not have anything to suggest chronotropic incompetence in these patients. So the most appropriate pacemaker mode for this patient would be the option C, which is the DDD. So that would be a pacemaker because it has complete heart block already. That would be a pacemaker that is dual chamber, with pace, with sense, and then has ability to inhibit or to track as well. So option C will be the answer for 413.
Okay. Thank you, Dr. Etubi. Okay, but considering that someone that has a complete heart block will definitely have bradycardia. So how would the bradycardia be taken care of? Because this is, although that wasn't given in the information, it was just stated that the patient has a complete heart block following aortic valve surgery. So why not option D? Just want to learn from that. Thank you.
I asked myself the same question when I looked at it. Thank you very much. The only thing is that, we're looking for, we're picking an option which is most appropriate. And in that question, we don't have anything that is suggestive of chronotropic incompetence. And because before you can choose DDDR, and there should be something that suggests that there's some chronotropic incompetence, and that could be due to an abnormal or absent SA node function. So when you have that, that is when you have to, use that pacemaker. But for this particular question 413, we don't have anything to really suggest. That's what I know about this. But I think it's open if there are more comments that can help clarify this. Thank you. Sorry, can anyone add any comment or make it clearer, this question?
Well, I think that when Prof takes us, maybe we'll be able to sort it out if no other person have any further comments. I will just note the question down. Thank you.
Thank you very much.
Hello.
Let me just, okay, go.
Let's go on.
Yes, Dr. Conte.
Oh, okay. I just want to add, like the presenter has mentioned, no indication of sinus node dysfunction was stated in that patient. So they might not need a rate responsiveness. Because the thing is, once the SA node is intact, the atrial lead will most times just be doing sensing and sensing the normal, sinus rhythm, and then pacing the ventricle to maintain that sinus rhythm. And once every connection in the SA node is intact, the patient has not undergone any heart transplant. So all the normal physiological response of the SA node will be functional. So the person will be able to maintain a good heart rate, even if he decides to exercise. The sympathetic, the SA node will respond appropriately to sympathetic stimulation. And once the dual chamber device senses the atrial activity, it's based on that it will pace the ventricular, it will pace the ventricle. So such a patient would not need a rate responsive pacemaker. Thank you.
Thank you, Dr. Conte. Thank you for the clarification.
Dr. Rukaya, I think you wanted to say something.
Well, I was going to say the exact same thing, that since it's AV block, the problem is third-degree AV block. So the sinus node is normal, and the dual chamber pacemaker can sense that. And so that was my contribution. Thank you.
Thank you, ma.
Thank
Dr.
you,
Alex.
Dr. Ruki. So the last part of that we're to pick from question 414 now talks of a 45-year-old man with symptomatic sinoatrial exit block and an appropriate escape junction. 45-year-old man with symptomatic sinoatrial exit block and an appropriate junction now escape reading. So for that one, please can you go back so that we can follow? Thank you. For this one, we can see that there's no evidence of AV block. Just like what Dr. Ruki was saying just now, there was no evidence of an atrioventricular block. Because what favors the use of a dual chamber is actually the aspect of AV nodal disease. If there's no established AV nodal disease, and there's just, let's say, sinus node dysfunction, what to be preferred is something that has to, a pacemaker that has to do with atrial inhibited pacing or atrial pacing. So for this patient that was described as 45-year-old that had a symptomatic sinoatrial exit block, there's no evidence to show that there's an AV block. So ventricular pacing will not be supported or necessary in this patient. So you find out that the AAAI are may be preferred in this patient. That's the atrial pacing, atrial sensing, and then the response being inhibitory, and then there's a rate modulation in this patient, because already there's an exit block or a junctional escape reading, but focusing more on the atrium. So there's no need for something that would support or work on the ventricles. So that makes question 414 option E, the AAIR. Thank you. Please, is there any further comment or clarification on this?
Thank you very much. Let me just drop this because I used to confuse the sensing pulse pacing. So I use a code, Pharmacological Society response rates. And this allows me to remember that pharmacological, that I have to pace before I sense, then the response and the rate. Just for any other person that will find it useful. Thank you.
Great. Thank you, Andrew. Another way is to know that P comes before S.
Yes, exactly.
So letter P comes before S. So you pace sense, then the response to the sensing could be inhibitory or triggered, or there could be no response. And then the other aspect of rate modulation, depending on if there's chronotropic incompetence or not. Thank you. Okay, if there's no more comments, we'll move to the next. The questions are in blocks of 4s. Excuse me. So now 415 to 418. For each of the clinical description, match the corresponding etiology of dilated cardiomyopathy with electrical instability. If we're to match the corresponding etiology of DCM with electrical instability, excuse me.
Please continue, sir.
The first clinical description is, okay, the options, option A talks about cardiac sarcoidosis. Option B, giant cell myocarditis. C, Chagas disease. D, arrhythmogenic right ventricular cardiomyopathy. And then E, cardiolaminopathy. So we're to, for options A to E, we're to match the clinical scenarios 415 to 418. 415 reads, a 30-year-old man with a history of syncope who is found to have low amplitude deflections on the ST segment in the right precordial leads and abnormal desmosomes on cardiac immunohistochemistry. 416 clinical scenario is on a 38-year-old man with GI dysmotility, complete heart block, and an apical aneurysm. Question 417 is on a 50-year-old woman with a history of restrictive lung disease who presents with syncope in the setting of first-degree AV block and right bundle branch block. And the 418 is on a 42-year-old woman who with rapidly deteriorating cardiac function, frequent burst of ventricular tachycardia, and widespread myocyte necrosis on endomyocardial biopsy. So as we go back to 415, and then we have to pick from options A to E. A 30-year-old man with history of syncope who is found to have low amplitude deflection on ST segment in the right precordial leads. Or let me just say a little on the clinical description or the conditions listed up. For example, starting with sarcoidosis, cardiac sarcoidosis. We remember that is a multisystemic disorder, and the cause is not known, but it is characterized histologically by non-cassating granulomas, a strong differential for pulmonary tuberculosis, but tuberculosis has cassating granuloma, which is having a central core of dead cells or tissues. But in the non-cassating form of granuloma, which is what is seen in sarcoidosis, they do not have that constellation of dead tissues in the center. And sarcoidosis is said to be commoner in blacks, and it is more in females compared to males, and higher in certain parts of the world, Scandinavia countries, Norway, Sweden, Denmark, and also it's high in Japan. It used to be thought to be less than 5%, but more recently at autopsy, and then because of increasing cardiac imaging modalities, it is said that close to about 25% of patients with pulmonary sarcoidosis actually have cardiac sarcoidosis as well. And sarcoidosis has lots of cardiac involvement, and it takes different forms from ventricular dysfunction to heart blocks and to even ventricular, arrhythmias. And it's one of the things we must always remember about it is that it does not just affect one aspect, of cardiac function. It affects different aspects, and it can cause heart block and arrhythmias, like I said earlier on. So for the most of them, we know that the most common site of non-cardiac involvement in them is the lungs, and more than half of the patients that have this lung involvement will have parenchyma disease and then hilar lymphadenopathy, which can be picked on X-ray. And like there are stages of sarcoidosis even on X-ray, stages 1 to 4. Then there are other organs that can be affected in sarcoidosis, like they can have hepatic involvement, GI, ocular, even neurologic and skin involvement. But the most common clinical feature of cardiac sarcoidosis, for cardiac sarcoidosis, the most common clinical feature is that they can present with biventricular heart failure, mitral regurgitation, which is usually due to papillary and muscle involvement, and it can be severe. For diagnosis, we know there are different investigations that can be done. For example, they have elevated ESR, even though that is non-specific. They can have hypercalcemia, which is due to activation of vitamin D by macrophages. And they can have elevated serum angiotensin converting enzyme levels. But it has been seen that even those who do not have, you can have normal ACE levels in sarcoidosis as well. So that's not very specific. Then cardiac magnetic resonance imaging can be done with gadolinium enhancement. Okay. And then, but the hallmark is actually a tissue biopsy, which shows a positive non-caseating granuloma, and that is diagnostic as long as we have ruled out giant cell myocarditis. So if we come back to our patients, to our case for discussion, back to the options we're discussing, that was just a brief talk on sarcoidosis. The other one is the giant cell myocarditis. The giant cell myocarditis is a condition that what is notable about giant cell myocarditis is the fact that it has an aggressive and rapid progressive course. So if you get a history of like, I think one of the options talking
Dr. Alex, please let's be patient for him to come back. Thank you, Sir Zamas. Dr. Alex, are you back? Okay. I think his network went off. I don't know. Should we continue answering the question, or let's wait for him for about 1 minute? Thank you. Oh, please, what's our suggestion?
Let's wait a little for him now and see if we can get better. Maybe if we don't speak, we have to think otherwise. My thoughts there.
Yeah, I'm suspecting that maybe the problem is okay. It's back. Dr. Alex, welcome back.
my network just went off. Thank you. I'm not sure where you heard me last. Dr. DeAndre.
Yes, please.
We're talking about Chagas disease. I don't know if you heard.
Yes.
And we
Okay,
stop
that's
giant cell myocarditis.
okay. Giant cell myocarditis is one of the things we should remember about it is the rapid course. You will just hear of a patient who rapidly deteriorates, like in one of the clinical description we have, and it's usually composed of widespread necrosis with giant cells on histology. And most times it is associated with autoimmune disease and a thymoma, right? So, and the next thing, which is the Chagas disease is caused by a protozoan, the Trypanosoma cruzi, and then it is endemic in certain parts of the world, Central and South America. It has a number of non-cardiac manifestations, and notable amongst them is the gastric or the GI dysmotility. But cardiac disease is also known to have notable cardiac involvement and can cause, conduction abnormalities, and it can cause apical aneurysms, and it can even lead to ventricular, tachycardia. So it's a significant cause of heart failure in certain parts of the world. Then for arrhythmogenic right ventricular cardiomyopathy, it's an inheritable disease or disorder. And what is typical of this is that you have the typical monomorphic VT pattern that is characterized by left bundle band block morphology, and with the typical T-wave inversion that extends up to V3 and sometimes beyond V3, and the classical epsilon wave in the right precordial leads. And the presence of this epsilon wave on ECG for ARVC is specific, but it is insensitive. And most times those who are affected, they are young adults in most cases. And the major challenge in the ARVC is that you have a replacement of the normal muscle, cardiac muscle, with fibrofatty infiltration. And then that is seen in the desmosomes, which is one of the proteins that we have in the cardiac muscles. So the typical appearance is actually seen on immunohistochemistry. And this is when you have a disruption in the desmosomes, and then it can lead to loss of the cell-cell signaling, because we know how the cardiac muscle cells are arranged to ensure or allow for transmission. So for the cardiolaminopathy, that's an autosomal dominant form of dilated cardiomyopathy, and it results from a mutation of the LMNA gene, and the cause is variable and subtle. It can also cause some conduction system abnormalities, especially first-degree AV block. So if we look back to the questions being asked now, in question 415, a 30-year-old man with history of syncope who is found to have low amplitude deflections on the ST segment in the right precordial leads and abnormal desmosomes on cardiac immunohistochemistry. One, you see this is a young adult, 30-year-old, and you see the description that is given of the ECG findings, and then the distortion in the desmosomes of cardiac immunohistochemistry. That option is actually a description of arrhythmogenic right ventricular cardiomyopathy. That fits, so 415 fits option D. So 415 is D. Then 416, a 38-year-old man with GI dysmotility, complete heart block, and an apical aneurysm. This is the kind of picture we find in patients who have Chagas disease, the protozoan disease transmitted by Trypanosoma cruzi. So one of the notable things they have, apart from their involvement with conduction abnormalities of the heart, is they have this GI, this motility. So that option best fits for option C. So 416 is C. Then for 417, which is a 50-year-old woman with a history of restrictive lung disease who presents with syncope in the setting of first-degree AV block and right bundle branch block. And that best fits with cardiac sarcoidosis because this patient is 50, already has a history of restrictive lung disease, which is the pattern we have with respiratory sarcoidosis. And approximately 25% of those who have respiratory sarcoidosis, they already have some form of parenchymal disease and hilar involvement. And most of them have, about 25% of them have cardiac involvement. So 417, the answer is actually A, cardiac sarcoidosis. Then for 418, talks of a 42-year-old woman with rapidly deteriorating cardiac function, frequent burst of ventricular tachycardia, and widespread myocyte necrosis on endomyocardial biopsy. So once we get this picture of a rapid deterioration, a rapid progressive course, a rapid clinical case, and then with widespread necrosis and presence of giant cell biopsy, that is actually a description for giant cell myocarditis. Thank you. Please welcome more additions or comments to this aspect. Thank you. Hello, am I being heard, please? Just to be sure.
Yes, sir. Thank you.
Thank you. Please, is there any contribution or addition to this? Thank you.
They will call you back if there is
Okay,
Let's continue.
thank you. So please, can we move to the next aspect? Okay, so I'm to take 419 and 420, but since it's a block, we just have to take them together, 419 to 423. Says for each of the following conditions were to match the corresponding clinical presentation of syncope. The first condition is a 20-year-old woman that blacked out during phlebotomy for a routine blood test. Option B is a 65-year-old woman who lost consciousness after arm exercises. Option C is a 35-year-old man who sustained syncope during exercise and has a systolic murmur that intensifies on standing upright. And D is a 74-year-old man who experiences sudden syncope while shaving. And then E is a 28-year-old woman with recurrent episodes of breathlessness, lightheadedness, and syncope after changes in body position. So we're to use this following presentation to match 419 to 423. 419 is hypertrophic cardiomyopathy. 420 is subclavian steal syndrome. 421 is vasovagal syncope. Dr. Lekon, please, can you just move together? 422. 422 is carotid sinus hypersensitivity, and then 423 is left atrial myxoma. Thank you. Please, can we just go back again? Thank you for moving the slides. Appreciate. I think we discussed syncope sometimes back, and I think it was remodeling dynamics of how that even from a good clinical history and physical examination, we can begin to have an idea or have something suggestive of the cause of syncope. Because, for example, if we're discussing syncope in the setting of a patient who has hypertrophic cardiomyopathy, typically that will occur with exertion. And then if we do an examination, we'll find out that the murmur is accentuated or is associated with the dynamic left ventricular outflow tract obstruction. And then mostly in hypertrophic cardiomyopathy, you would be able to relate the syncope with exertion, and that is very key in them. While the, patients who have the subclavian steal syndrome is usually as a result of stenosis, atherosclerotic stenosis of the subclavian artery. And this is usually occurring proximal to the vertebral artery. We know that the vertebral artery joins together to form the basilar, and then from the basilar forming the posterior circulation, and they're part of the circle of Willis. So because of this location of this stenosis in the subclavian artery, during it can lead to some form of cerebral ischemia in these patients, which is a cause of syncope, in them. Then for vasovagal syncope, is also known as the neurocardiogenic syncope. One way we would remember this is that it always occurs suddenly and is as a result of maybe an unpleasant sight or unexpected pain, loud sound or smell. And it can also occur, the vasovagal can also occur after prolonged or long standing and after going through a stressful situation. So a good history and examination can actually give an idea of what the cause of this can be. Then when you talk about the carotid sinus hypersensitivity, it's usually as a result of stimulation of the carotid sinus baroreceptors. So when they are stimulated, and then you find out that this is usually as a result of applying pressure to the carotid sinus. When pressure is applied over the carotid sinus and the history of syncope is gotten, we can suspect that this may be carotid sinus hypersensitivity. And then it is usually seen like during or after shaving, just during shaving, as the individual shaves and places pressure over those baroreceptors, they can become overly sensitized. And then when one also wears tight, shirt collars, these can put pressure on the carotid sinuses, which can lead to a hypersensitivity, and then there'll be a decrease in blood levels circulating, and then that can cause the syncope that these patients can have. Then the last part, the atrial myxoma, which is the commonest cardiac tumor, benign cardiac tumor. Because of its location, it can actually lead to syncope. And then what you hear about the atrial myxoma kind of syncope is its association with, changing posture, which can be as a result as a shift. When the tumor shifts transiently, it may be able to cause some obstruction in the mitral orifice, which would also affect the effective amount of blood that's followed. And that can lead to syncope. So if we go back to the question to try to see how we can now tease them out or match them with the corresponding clinical presentation. In this option A, which is a young person, 20-year-old woman, and she blacked out during phlebotomy for routine tests. So that option actually matches best with vasovagal syncope, because vasovagal syncope, like I said earlier on, can be from an unexpected pain or sight that is unpleasant, can be from a sound, it can be from even prolonged standing. So possibly this 20-year-old has never, some people have this phobia for blood. So it might just be the sight of the blood or the quantity that was being taken or maybe the pain, and that can cause a syncope. So, oh, sorry, I'm jumping the gun. Let me go back to 419. Sorry about that. I'll rather go to the question and then match with the clinical scenario. So in 419, it's on hypertrophic cardiomyopathy. So if we look at all the options in hypertrophic cardiomyopathy, what is cardinal in them is that we'll find that it's during exertion or exercise, and then the murmur is accentuated when we listen. So if we look at the options, option C best fits into this: a 35-year-old man who has sustained syncope during exercise and has a systolic murmur that intensifies on standing upright. So 419, the best clinical presentation that matches this is option C. Then for 420, subclavian steel syndrome, which is usually as a result of atherosclerosis and the subclavian. The best option that fits this is option B, the age of this woman. And then usually it is associated with what is called arm exercises or activity that involve using the arm. And that will further cause some narrowing of stenosis in the already stenosed subclavian artery. So the best option for 420 is actually option B. Then for 421, talking about the vasovagal syncope, like we said, occurs when there's an unpleasant sight or unexpected pain. So that would match more with A, the 20-year-old blacked out during phlebotomy for routine blood test. Dr. Lekon, can you move a bit? I know 422 is on carotid sinus hypersensitivity. And for carotid sinus hypersensitivity, okay, sorry, please just go back since we carotid sinus hypersensitivity and then left atrial myxoma. Thank you, sir. Please just move back to the, so for carotid sinus hypersensitivity, usually as a result of stimulation of the carotid bioreceptors. And in this case, we have, no, sir, the clinical scenario. Thank you. Please, can you just move the slide to, thank you. So if we look at that 422 that is talking about carotid sinus hypersensitivity, when we check option D, we see that it's a 74-year-old man that experiences a sudden collapse while shaving. We said it is associated with pressure over these carotid sinuses, can be from shaving or wearing white shirts, neck collars. Then the last option, 423. I think 423 matches well with option E, which is a 28-year-old woman with recurrent episodes of breathlessness, lightheadedness, and syncope after changing position. Even though it's not a very common cause, but left atrial myxoma, can cause these symptoms, especially when the tumor shifts and maybe transiently obstructs or covers the mitral orifice. So that's for these aspects. Please welcome more additions or comment to this. Thank you.
Thank you very much. Hello, who is presenting next, please?
Okay, thank you.
Thank you, sir.
It's supposed to be Dr. Hago, but it took an excuse. That's from 4. That's supposed to be from 4:01 to 4:10.
All right. All right.
I don't know whether we should go back there or we should continue with this part.
Can anybody help us with it, or should we read it? Or we can't just let it be now.
Well, let me try. Maybe we can all work together on it.
All right. All right. Thank you very much.
Thank you. Dr. Laleko, please kindly go to 4:02 to 4:10. Thank you. Okay, thank you very much. Thank you so much, Dr. Laleko. So I'll be attempting to answer this, and sincerely, I'll need help from everybody. So question 403 to 406. Assume that you have decided to prescribe antiarrhythmic drug therapy to prevent recurrent episodes of atrial fibrillation for each of the patients described below. Match each patient with the most appropriate antiarrhythmic from the provided list. So we have A, flecainide, B, sotalol, C, amiodarone, and D, mexilectin. Now, we've talked about antiarrhythmic agent yesterday, and we know that flecainide is class 1C drug, and what it does is that it acts on sodium channel and also shortens the action potential, and it is indicated in persons with no structural heart diseases. That's for flecainide. For sotalol, it's just a recap from yesterday. We have been told yesterday, sotalol is a class 3 drug, and what class 3 drugs mainly is to block potassium channel and they prolong utilization. Same goes for amiodarone, which is a class 3 drug. Then we have mexilectin. I think we were told yesterday that that's class 1B. Yes. It also prolongs the action potential duration and reduce the rate of rise of the action potential upstroke, while blocking sodium channel. But here we are discussing with respect to atrial fibrillation what the best drug will be. So I'll just try and go ahead and read the question and figure this out. So question 4.3 says, is this 4-year-old man? Please, am I audible?
Yes, you are audible. I can hear you at least. I don't know about others.
Thank you, Chief, sir. So,
okay, sorry, Dr. Malade, can I read something out? Maybe it's going to now help us answer it.
Please go ahead.
I don't know. I have a jotting on rhythm control in AF using these drugs. So, flecainide is contraindicated in left ventricular dysfunction, coronary artery disease, and moderate LVH. Is contraindicated in left ventricular dysfunction, coronary artery disease, and moderate LVH. Sotalol is contraindicated when ejection fraction is less than 40. Then amiodarone can be used in almost all the cases. almost all any case. Then which one again? Sotalol. Okay. Then okay, there's no propafenol. 1, 2, 3. Okay, that's all. 3 of the drugs that are here. Those are what I've said. So I don't know whether I'm sure it's going to help us aside.
Thank you
Chief
so
Thank
much.
you.
Chief Alawish, sorry, just a little clarification. Flecainide is not used in any left ventricular dysfunction. All the spectrum of left ventricular dysfunction, diastolic dysfunction, systolic dysfunction, hypertrophy, what exactly? You have an idea of what they mean by not
That's what I
using
said.
left ventricular dysfunction?
I said it's contraindicated. Is contraindicated in left ventricular dysfunction, coronary artery disease, and LVH.
No problem.
Okay.
No problem.
Thank you so much. This have helped greatly. So I'll read the option.
Okay.
A 64-year-old man with remote history of anterior myocardial infarction and left ventricular ejection fraction of 50%. 404, a 74-year-old woman with long-standing hypertension and left ventricular hypertrophy, wall thickness greater than 1.6 cm. Question 405, a 58-year-old man with non-ischemic cardiomyopathy and class 3 congestive heart failure. 406, a 46-year-old man, otherwise elderly man with no structural heart disease. So I'll start from 406 and with what Dr. Alagbe have read. Thank you so much, ma. A 46-year-old man, otherwise elderly man with no structural heart disease. I think the correct option for this will be flecainide, which is a class 1C drug. I think propafenol too we should be able to use propafenol in this patient, but most times in the options, they will always put flecainide for structurally normal heart. So for question 403, with what Dr. Alagbe has just read to us with question 403, this is 4-year-old man with remote history of anterior myocardial infarction and preserved left ventricular ejection fraction. I will take B as the most correct option here. Most times after myocardial infarction, when they have preserved ejection fraction, class 3 drugs can be used for such people. Sotalol, dofetilide, dronedarone, amiodarone can be used. When they now have low ejection fraction, maybe non-ischemic cardiomyopathy with low ejection fraction or in congestive heart failure, you still use class 3 drugs, but for them, you consider more of amiodarone in such group of people. So for me, 405, I will be picking amiodarone, which is option C. Now we are left with 404. A 74-year-old man with long-standing hypertension and left ventricular hypertrophy with wall thickness of 1.6 cm. Okay, with what Dr. Alagbe have read, I will have gone for option C, but please, we need more comments and contribution. Thank you.
You're right.
Okay. Thank you very much, ma'am.
You're welcome.
Please, any other contribution, or should I go ahead, please?
Move on, please.
All right. So we quickly go to 407 to 410, which reads, for each of the following diuretic agents, match the appropriate adverse effects. Option A, ototoxicity. Option B, gynecomastia. Option C, metabolic acidosis. Option D, hypercalcemia. Option E, hyperkalemia. I will just quickly tell us about diuretic agents and their point of action in the nephrons or the renal system. So for diuretics, we have the carbonic anhydrase inhibitors. An example is atezolamide. And where this acts, it acts on the proximal convoluted tubule, if I remember correctly, and that is where carbonic anhydrase acts on the nephron. For loop diuretics, we can all remember that it's common. So most is on the thick ascending limb of Henle. Sorry. And it blocks the sodium potassium chloride co-transporter. So thick ascending loop of Henle, that's where it acts. For thiazide-like diuretics, their own action is to block sodium chloride rather at the distal convoluted tubule. So that's where thiazide-like diuretics work. And for the MRAs, which are potassium-sparing drugs, I think they also work at the collecting dot. I cannot remember whether it's proximal or distal, but that's where their action is. The thing about diuretics is that they just give symptomatic relief in heart failure, and majority of them, however, they increase sodium and water. They increase excretion of sodium and water, therefore reducing the edema that we see in patients with congestive heart failure. So for looking at their side effects, we can all remember that thiazide-like diuretics or thiazide diuretics mainly, they cause hyperuricemia, which can lead to gout. They also cause hypercalcemia. For the thiazide-like, they have more of hypercalcemia than hyperuricemia. Therefore, MRAs, because they are potassium sparing, they will cause hyperkalemia in patients. For the loop diuretics, they can have all the electrolyte derangement present in them. Then for which one again? Acetazolamide, what they have majorly is ototoxicity, and we are to be careful when we want to use them with aminoglycoside, which also have effects. So with this brief overview, I will try and attempt the question. So for option A, which says ototoxicity, I'll be thinking that 407 will be acetazolamide, which is recognized to cause ototoxicity in patients. So 407 will be A. 408, metolazone. Metolazone is a diuretic. No, it's a thiazide-like diuretic rather, sorry. It's not just a diuretic. So for a thiazide-like diuretic, I said that they will cause hypercalcemia, and thiazide will cause more of hyperuricemia. So for metolazone, I'll be picking option D for metolazone. Then for 409, which is torsemide, that's inhibit the sodium potassium chloride in the thick ascending limb of Henle. So for that, torsemide, let me leave that one for now. For 410, that's eplerenone. MRAs have been known to cause, apart from them having potassium sparing effects, they also cause gynecomastia and other things. So for 410, I'll be thinking that the option will be B. So I'm left with torsemide. For this torsemide, I'm actually looking for electrolytes abnormalities, which I can't readily pick up here. So please, I need help for torsemide. Thank you.
Hello.
Okay, Dr. Adeyanju.
Okay.
Hello. Torsemide, actually, all loop diuretics cause ototoxicity.
Yeah.
Furosemide, torsemide, bumetanide. Furosemide has the highest risks of causing ototoxicity. I think followed by bumetanide, then torsemide or something. But they are known to cause ototoxicity. That's the loop diuretics. And they are sulfonamide also. They are sulfonamide containing drugs. because I've seen patients that react to torsemide and furosemide. So they give this something like Stephen Johnson. So they cause ototoxicity and they are sulfonamides. So they cause ototoxicity. Then from literatures I've read, eplerenone causes gynecomastia, but it's not that bad. Because I know most patients that are on aldactone, that's spironolactone, once they start complaining of gynecomastia, we switch them to eplerenone. Like it doesn't cause gynecomastia as bad as aldactone.
Right?
Then the last one is in that class, there's spironolactone, then eplerenone, then is it finferinone? That one doesn't even cause gynecomastia at all. So I think that's what. So
Thank you.
torsemide is ototoxicity. Like I've seen it, like patients that we give that came back with hearing impairment. Thank you.
Thank you. So that means with what you've said, torsemide is actually A.
Yeah.
I mean,
Yes.
A. Yes.
It's A. Yes, torsemide is A.
410
And just
is
know the other, furosemide is the worst, then torsemide, then bumetanide.
okay, right. FTB. Okay.
Thank you, Ade. I probably thought that acetazolamide now, it blocks the transaction of carbon dioxide to carbonates, helping us to colonize this thing. So I think that one we should either go with C, metabolic acidosis. Thank you very much.
No, thank you. Okay, that will be because of the carbonic that is being lost, right?
Yes, yes.
Okay.
Thank you very much, Ade, for saving up on this.
Thank you, sir.
Next
So
presenter, please.
Sorry, please. It's outside this, so please, I just want to add, because I saw acetazolamide, there's one trial that came out last year. Was it last year or upper year? Advert trial, where they encourage using acetazolamide now in heart failure patients. So please, let's go through it because we don't know whether it's papers that they go and use and set questions for MCQ. Thank you.
Could you help us with it on the blog? Can you upload it to the blog?
I'll put it on the chat group.
Oh, thank you very much.
I'll put it on the chat. Yes.
Thank you very much. Let me quickly go through this again. So that means 407 is C. 408 metolazone is D. 409 is A and 410 is E. Right?
Yes.
Yeah, correct.
Sorry, what's
Sorry, I didn't hear that.
what 10?
410. 410 is hyperkalemia. You know, they are potassium sparing. For 410, if they've put or spironolactone, you will have gone for gynecomastia. But with what has been explained, most of patients with gynecomastia, you give them eplerenone because of that side effect. And Dr. Alagba just said that there is finerenone too in this group. So you pick hyperkalemia here, not gynecomastia. So the correct option is E for 410.
Thank you.
Please, what about 408?
408 metolazone. That's hypercalcemia. Hypercalcemia. But if you have hyperuricemia too here, is the correct option.
Okay, thank you.
So that is option D. Please, any other comments or contribution?
Thank you very much. I think the next presenter can come on, please.
Yes.
Thank you, Ade Andrew.
Thank you. Thank you for helping me out. Dr. You
Thank you.
Please.
Thank you, Dr. Ade Andrew. Thank you, Dr. Uzoke. I'm taking question 424 to 427. Questions 424 to okay, the to 431 now because it's a block question also.
You're welcome, my president.
Thank you so much. Happy to be back anyway. I've been battling with some challenges.
You're welcome, sir.
All right.
Happy to have you.
So 424 to 427 it says for each condition capable of precipitating high output cardiac failure, match the appropriate physical findings. And if we look at the options, we have hyperthyroidism, we have beriberi, we have arteriovenous fistula, we have carcinoid syndrome, and then we have E as Weber-Rendu syndrome. Now, question 424 stipulated the Nicola-Doni-Braham sign, and then 425 hepatomegaly and abdominal bruise, 426 means Lehman scratch, and then 427 paresthesia and painful glossitis. Well, this also, just like the other questions we've been answering, we'll take them by elimination method. And if we look at the Nicola-Doni-Braham sign, right, which particularly has to do with systemic arteriovenous fistula, is actually described as a slowing of the heart rate after manual compression of the fistula. Is a maneuver that also try to raise arterial blood pressure, and then also lower the venous blood pressure. So if we take it back to the options, and then of course the arteriovenous fistula is there, is much related to it. Is well, it's named after the man that discovered the phenomenon. Once you have an heavy fistula and there is a manual compression of that fistula, then the heart rate slows without affecting the arterial pressure. But in most cases, the arterial pressure also gets high. The next one is hepatomegaly and abdominal bruise, and we now look at options that are available. And we'll take a look at the Osler-Weber-Rendu disease, which commonly is a hereditary hemorrhagic telangiectasia, which also include an AV fistula, but then it doesn't have to do with what we saw in the Nicola-Doni-Braham side. And this condition may also occur, especially in the liver and the lungs. Of course, it's a hyperkinetic disease and is also associated with an abdominal bruise. So if we now know that this condition goes with hepatomegaly, abdominal bruise, and then intrahepatic AV connections, then the Osler-Weber-Rendu syndrome is the appropriate answer, which is E, is the appropriate answer for 425. So 424 is C, and then 425 here is E, Osler-Weber-Rendu syndrome. Now, 426 is Lehman scratch. Okay, when I was reading this up, I discovered that it has to do with hyperthyroidism. Hyperthyroidism, in addition to all the neurologic manifestations that we see in young patients with diaphoresis, nervousness, heat intolerance, fatigue, the cardiovascular manifestations would also include this mid-systolic along the left sternal border. Of course, that had to do with this increased flow. And it's also described that there is a scratching sign that usually occurs with this smoke. And it's thought that this is caused by the rubbing together of the normal and pericardial surfaces, the normal pleural and then the normal pericardial surfaces come together at that particular period of that way systolic to give that scratching sign. And that scratching sign is named the Meslehman scratch. So this Meslehman scratch is the correct answer for it here is A, which is hyperthyroidism. Of course, we are left with 427 paresthesia and painful glossitis. So between option B, beriberi, and then option C, carcinoid syndrome. The appropriate answer here will be B, which is very good. It has to do with vitamin thiamine deficiency. Of course, with thiamine deficiency, we are found to have a lot of these peripheral neuropathy with paresthesia of the extremities. There are, of course, other things that may be associated with this has to do with decreased or absent knee and ankle jolts, hyperkeratinized skin lesions, and then the painful glossitis. Now, of course, they can also have edema, in which case we are talking of which beriberi, which differentiates this condition from the dry form. Of course, the carcinoid syndrome is also one of the hyperdynamics, but it doesn't have any appropriate number for it here. So that's this us with 424 to 427. So the Nicola-Doni-Braham sign is seen in AV fistula, where with smaller compression of the AV fistula, there is a reduction in the heart rate without also affecting the arterial pressure and venous pressure. Then the hepatomegaly with abdominal view in the absence of neonatal is the Osler-Weber-Induced syndrome, which occurs at that point. And then the Meslehman scratch gives us A, which is seen in hyperthyroidism. And then the beriberi, that is the option B for 427. As for 424 to 427. Any further inputs? Okay.
Please, what's the answer to 427, please?
Okay, 427. Okay, and yeah, the answer to 427 is, of course, we know what beriberi does. Is essentially has to do with thiamine deficiency. And it's also important that we also note here that in chronic alcoholics, if a patient has already developed alcoholic cardiomyopathy, it's also possible that there will be exacerbation of this condition because of thiamine deficiency that is also associated with chronic alcoholism. So the answer to 427 is B, beriberi. The painful glossitis gives it out. In the absence of the paresthesia, the paresthesia with painful glossitis. And then when you look at the other options available there. Okay. Do I move on?
Move on, sir.
Okay.
Anyone ask question, they will ask.
Okay. So the next set of questions is 428 to 431. And in our numbers, we have 428 as a tenable, which we all know is least lipid soluble. So then we have 429, that's carvedinol, which of course has the alpha and beta effect, and then there's acetabuterol, which is cardioselective with sympathomimetic activity, and then the pendulum. Now, if we now, of course, I'm going through this session of beta blockers, we can go into it and keep seeing it about it. So, of course, it's one of the areas that they will keep asking around. If we look at the options we are matching with, say for each of the following descriptions, match the appropriate medication. One of the lists lipid soluble beta blocker. And if we look at 428, really, atenolol, carvedilol is appropriate answer here. Is the least lipid soluble that we will have in this option. Of course, the other one is nadolol, but nadolol is not here. We'll pick atenolol. 428 is A. That's atenolol. Now, 429, carvedilol, if we now look at the options here, we have B, cardiosedative beta blocker with intrinsic sympathomimetic activity. It cannot be beta blocker with an alpha blocking activity. So, carvedilol here, the answer here is C, because it's beta blocker with an alpha blocking activity. Now, 430, question number 430 is acetylbutalol. And just as we discussed several, acetylbutalol is a cardiosedative beta blocker with intrinsic sympathomimetic activity. And in that category, 430 now should be B. Acetylbutalol, 430 is B, cardiosedative beta blocker with intrinsic sympathomimetic activity. It's also important here that we should also remember the other sedative beta blocker, like atenolol, metoprolol, esmolol. They are sedative beta blockers, but they don't also have the intrinsic sympathomimetic activity. Now, 431. 431 is pindolol, and then when we read down the options here, we have beta, we have non-selective beta blocker with intrinsic sympathomimetic activity. And then if we now look at pindolol, of course, that's the right option. A non-cardioselective beta blocker. So the two of them have been placed side by side. We have 430 acetylbutalol, which is a cardioselective beta blocker. We have 431 pindolol, which is a non-cardioselective beta blocker, and then the two have intrinsic sympathomimetic activity. And we've handled these sessions severally, and it's something we'll keep going through and then keep reminding ourselves of them and finding a way to memorize them. Been trying to find a mnemonic for them. If anyone has a very better mnemonic for these things, let him keep sharing. I think with this, I've taken that session my own question 424 to 431. It's actually 4. It should actually start from 421, but 421, 422, 42 had already been taken by the person that spoke first.
Thank you, Chikunye Boyza.
Thank you.
So next person to present, 432.
That's supposed to be Dr. Prince, but it's not ready. So I don't know whether we should take it together or other person that is ready in the class. But if you can take it together, I think it's better. Can anybody in class help us with this aspect? Or Dr. Uzuki, can you?
All right, just a second, please.
Thank you, sir. That's all. It's okay. Are you still there? Or should I just read out and sort it out? Chief is okay, sir.
Oh, sorry, I've been muted since. I've been saying hello since.
I was wondering, sir.
Please,
Sorry.
could you help us project the question again, please?
Dr. Olali Consa, can you please help us share the screen again? Thank you.
Okay. Last part of this section. Questions 432 to 435. Here we have the table ABCD. We have normal as end diastolic volume as 70 ml per meter square. Stroke volume is 45 ml per meter square. And left ventricular mass as 92 grams per meter square. A, we have end diastolic volume as 84, stroke volume as 44, and left ventricular mass as 172. Okay. B, we have end diastolic volume as 193, stroke volume as 92, and left ventricular mass as 200. C, end diastolic volume as 199, stroke volume as 37, and left ventricular mass as 145. D, end diastolic volume as 70, stroke volume as 40, and left ventricular mass as 80. All right. For each disease state, match the appropriate left ventricular volume and mass data. Now, aortic valve 432. Aortic valve stenosis with peak systolic gradient greater than 30 millimeter of mercury. Here we'll see that when we have aortic valve stenosis, it is associated with left ventricular hypertrophy, and that's where we have concentric hypertrophy. So here we should expect the left ventricular mass to increase, and most likely that whereas the diameter will reduce, that the volume will decrease. So what fits here best will be A, 432. I'm inclined to shade A as it. That is to say, there is a reduction in end diastolic volume, reduction in stroke volume, but the left ventricular mass is markedly increased, 172 as against 92. Now, 433, we have myocardial disease. That's primary dilated cardiomyopathy. In primary dilated cardiomyopathy, we should expect here to have eccentric hypertrophy or at least, yes, eccentric hypertrophy, in which case you have increased volume and increased left ventricular mass. That should be an expectation in the primary dilated cardiomyopathy. And here we have increased volume. Here is only B and C. And the increased mass too, out of that B and C, both B and C are increased the mass, but then the stroke volume will drop because the systolic function of dilated cardiomyopathy is impaired. So it naturally will go with C, where the stroke volume is lower. So myocardial disease, that's the primary dilated cardiomyopathy, will go with C, where we have increased diastolic volume, decreased stroke volume, and increased left ventricular mass. That's 433 now. Now 434. And 434, we have aortic regurgitation with regurgitant flow greater than 30 ml per beat. That's 434. Now, in regurgitant, in regurgitant heart disease, here we should expect both the volume and the mass to increase. Both the volume, the stroke, that is to say, the volume of the cardiac chamber volume was increased, the stroke volume will be decreased, and the mass will be increased. That is what we should expect in regurgitant mitral valve disease. And here, where we have diastolic volume increase is only C and B, and the stroke volume only is increased in B alone, and the left ventricular mass is increased in B. Yes, B and C. However, C has a low stroke volume. So this is in consonance with B option. So aortic regurgitation with regurgitant flow greater than 30 ml per beat will go for B. Okay. Now 435. In 435, we have mitral valve regurgitation with regurgitant flow greater than 20 ml per beat. Here we have mirror exactly what we saw in the echo finding with mirror in the cardiac chamber and wall findings. We mirror what we saw in the aortic regurgitation. That is to say, both the chamber will be dilated, stroke volume will be increased, and what's the other called? What is the other? Yes, and the mass will be increased. Mass increased, stroke volume increased, and the end diastolic volume will increase. That is, I will equally choose B again for this 435. And that ends that. I don't know if anybody will help us check the answer and see how correct we are. More contributions, please. Thank you.
Thank you very much, Chief Uzuke, for helping us to move ahead. I just want to ask that D part of the picture graph, what will fit into that? And like you've said, I agree with you. In aortic stenosis, you know that there is minimal change in the volume of the LV. However, there will be increase in size, giving us a concentric hypertrophy. Whereas in AR and MRO, we see both an eccentric hypertrophy and also an increase in the volume. So I agree with the answers you've given, but maybe somebody will still check the answer. But for that option D, which clinical scenario can we paint around it? The stroke volume is read.
That option D can go for restrictive cardiomyopathy. Restrictive. In that place, we don't expect the muscle to be enlarged. We don't expect the volume to be enlarged. And of course, I don't expect stroke volume to be enlarged.
Okay. Thank you very much.
Yeah. Hello.
Yes, Chief Conte.
Yes. So even at that, we should qualify the kind of restrictive cardiomyopathy. So a restrictive cardiomyopathy that does not arise from an infiltrative disease, will give that. Because if you have an infiltrative disease causing the restrictive cardiomyopathy, then the mass index will increase.
Yeah, thank you, Chief Conte, for the details. Yeah, I think that's at 435.
Dr. Olalikon, please, can we check the answers and move to the next part, see if everybody's in agreement? Thank you.
Peripheral edema, the ECG shows no diffusivity wave inversions, and cardiac troponin T is 1.07 nanogram per ml. Reference range is less than 0.1 nanogram per ml. She receives aspirin, clopidogrel, intravenous unfractionated heparin, metoprolol, and atorvastatin. The chest discomfort persists despite IV nitroglycerin, and the coronary angiography is undertaken. Coronary angiography is undertaken. No coronary stenosis are found. Left ventriculography is performed. Figure 4.1. Which of the following statement is correct? She should receive anticoagulation warfarin for the next 4 months. An echocardiogram 2 months later will likely show apical akinesis. A recanalized coronary thrombosis is the likely etiology. This syndrome occurs predominantly in post-menopausal women. I expected in-hospital mortality is approximately 15%. Please, could we have a look at the figure 4.2? Okay. Okay. 4.2. Is it 4.2 or 4.1 that they wrote there? It's 4.2 now, right? 4.1.
4.1.
4.1, yes, sir. Four point two is up, sir. The ECG is 4.2.
No, it's a ventriculogram. So this is 4.1, the diastole and then the systole.
Okay, okay. Okay. Diastole, this is okay. Systole, the diastole. Can you reduce the zooming so that the two images can come in view? Oh, that's wonderful. Thank you very much, sir. Okay. With this, we can say that there is in the systole, we can see that there is an aneurysm of the left ventricle towards the apex, and giving us a typical water bottle shape. I think that this is what they call broken heart syndrome. That is that's Takotsubo, right? Yes, Takotsubo syndrome. Hope I'm right. Okay. Can we go back now to the options? Yes, sir. Thank you very much. She should receive anticoagulation with warfarin for the next 4 months. An echocardiogram 2 months later will likely show apical akinesis. A recanalized coronary thrombosis, likely etiology. This syndrome occurs predominantly in postmenopausal women. I expected in-hospital mortality is approximately 15%. I think by the fact that we have this dilatation at the apex of the left ventricle, I naturally will go for the anticoagulation and for the next 4 months. I don't know what the answer is. I don't think anyone has more contributions to make towards this. Thank you very much.
I don't know, but I think they brought out this something similar to this in one of the last exams, maybe 1.5 years ago, thereabouts. You rightly said, Chief, this is
Yeah, Dr. Zinjo. April
okay.
2023, general
If,
medicine. This is the question.
imagine that this is Taco
Yes,
one of the
it's
things that we
Subo. This was what came out.
imagine.
Serious.
One of the things we need to remember with Takosubo is that it's commoner in fact, it occurs in females more than 62 years old. And most times, maybe a sudden emotional stress, like it has been painted here. A bad news, like it was painted here, death of a husband, or maybe somebody stole somebody's money suddenly and stuff like that. But I know that they've also talked about stress, other stressors in Takosubo. So females postmenopausal, sudden news that they were not expecting. So that's the picture in them. And it has been said to be, the pathophysiology has been arranged around catecholamines, and that this is what causes the sudden change in the myocardium. And we class. Who is that? So at the president, Dr. Conte, okay, sorry. And classically, there is apical akinesia. It's also called broken heart syndrome. There's still another name for it. It was commoner in Japanese.
I think
And
it's
that
holiday art or something. Is it holiday art?
it's not the heart.
Okay.
I think
No,
it's an
holiday heart is related to
Takotsubo.
alcohol.
Takotsubo.
Takosubo, yes.
Heart,
Then apical ballooning syndrome and
yes,
stress-induced cardiomyopathy.
yes. And we have different variants. I think like 4 or thereabouts. So maybe I'll suggest that we'll take a topic on Takosubo to remind ourselves. I think we have like 4 variants of it. But commonly they have apical akinesia. And most of the antifailure regimen, or they don't need anticoagulation. Most of the antifailure regimen don't usually work, but I think they use ACE inhibitors in them. There's no need for anticoagulation. And with ACE inhibitors and I think beta blocker, they recover. And by 2 or 3 months, there will have been reversal in the akinesia in them. This from, well, I don't know. I'm just trying to recollect from my residual knowledge. I think that's what I can remember. So if I look at this option, sir, I will go for D.
Thank you very much.
Yes, I will
If
go
I
for
could just add,
yes,
thank
please.
you for the overview. So just to add, although it's more common in females, it can also be seen in males, and they have worse prognosis. Yes, and in addition to stress or bad news, actually extreme positive emotion can also trigger Takotsubo, even though less commonly. So some exciting news, somebody just received news that he won, I don't know, the lottery or something, and then they just develop chest pain and dyspnea and all of that. So it can also be seen in extreme positive emotion. Then of course it's a very close differential for ACS. Here, yes, ACS. So here they mention T-wave inversions, but typically it even presents with ST segment elevation. But it also has stages. So the ECG is dynamic, and at some point there could be T-wave inversions. So and the scenario that Dr. Alabe mentioned, they actually used a male patient. So I don't know if it was fair for general medicine, But they used a male patient and he had had surgery and he had hepatitis or something like that. So he was really through some stress. And then they gave this scenario. So the male was kind of it could have put people off. But let's keep that in mind. And that particular question, I think he was also 50 something, so not that old. But then they still gave the scenario to paint a lot of stressors at the time that he developed the pain and all of these features post-operatively.
Yeah.
Thank you very much. Okay.
Then
Okay,
maybe I should
sorry,
just add.
just to
Okay.
add, please. Okay, the reason why they have that affectation of the apex is because when there's release of catecholamines, okay, sorry, the apex has highest density of catecholamine receptors. So once there's release of catecholamines, it tends to bind more to the apex. That's why it's the apex that is more affected, not the basal part of the ventricle.
Thank you, ma'am.
Thank you very much.
I think it's
Yes.
also
Sorry.
important that we know that some complications can occur with this. Malignant arrhythmias, thromboembolism can also occur from this rupture of the left ventricle and even shock. So arrhythmias, embolism, rupture, cardiogenic shock, these are some of the complications that we can have from this, including, of course, most of these patients get admitted. Thank you.
Thank you. Also, in addition, I just wanted to it's also a form of all these Minoka. So there are also several other types in which patients they will have non-obstructive cardiac infarction, which can be due to different pathologies or pathophysiology or mechanisms. So this is one of them. You can also have vasospasm. You can have micro aneurysms. We can have microcirculation problems with the microcirculation. Another pathophysiology might be from dissection, scat. Another pathophysiology might be there are like 5 of them. That's what I can remember. Minoka. I'm sorry, Takotsubo is actually one form of the Minoka-Inoka syndrome. So they are all common in females actually, and they have atypical presentations. It's possible to do coronary angio like it was done here, and there will be no apparent obstruction. Yes, another example is myocarditis. Could also give the same, which will also give malignant arrhythmia, so as the case may be. Thank you.
Please type what you said. You said Minoka.
Inoka. That's the myocardial infarction,
Type it in the chat.
Please, could you type it and post on the WhatsApp blog? I beg.
Are you speaking Latin, French, or China?
Can you imagine? Minoka.
Yes. It sounded like a Minoko.
We are the next. True now. So it's Minoka.
Let's convert it to a Minoka.
By the way, they could have slight elevations in troponin.
This patient has elevation.
Oh, okay, fine.
This is a form of Minoka. This one too has elevation.
Sorry, I just remembered that. But one thing we must notice that because ACS is a closed differential, when you compare, when they come in, you're thinking of maybe ST segment elevation and everything. So you're thinking of an ACS, but by the time you do the troponins and everything, it's not as high as you will be like you will see in ACS. And then when you do the serial one, it won't be as high as you see in ACS. However, it's also elevated in them. Thank you.
Okay, sorry, can I just chip in something? The option that you picked was you said option E, which is you said the expected
D.
D. Okay,
Yes.
okay. Okay, okay,
like
thank you. I thought it
David.
was you. Okay, okay, thank you.
Thank you.
Dr. Ozuke, please continue. Thank you.
Thank you very much. Question number 437. Can you help me with the projection, please? Yes, thank you. A 55-year-old previously healthy man is brought to the emergency department because of left-sided chest pain over the past 3 hours. He denies shortness of breath or cough. The discomfort is less intense when he sits forward. The chest radiograph is unremarkable. The ECG is shown. In figure 4.2, which of the following statements regarding this patient's condition is true? 1, fibrinolytic therapy is indicated if cardiac catheterization is not immediately available. Nitrates will substantially relieve the chest pain. Non-steroidal anti-inflammatory therapy is indicated. Glucocorticoid therapy should be initiated immediately. Measurement of serum cardiac troponin I would clearly differentiate the cause of this chest pain. Can you help us now with the ECG on figure 4.2 again? Thank you very much. Okay. Okay, so when we go to view 1, we see that there is you can see arrow wave, the T wave is inverted. And slight elevation of QT, same with V2 and worse in V3. Okay. Then V4, the elevation is still marked in V4, V5, V6. Then late 1, still there in late 2, late 3. Then AVR has an inverted T wave. AVF, the same thing. AVF is elevated. And then reading stream, which is lead 2, is elevated ST segment and T wave. So if you see the diffuse nature of this ECG picture, one is tended to think of pericardial. So if we look at the diffuse nature of this ECG pattern, one is more inclined to think of a pericardial condition, that's pericarditis. So match these ECG findings with the chest pain that is relieved by leaning forward, then the diagnosis of pericarditis is more in tandem. So let's have a look at the options again. Thank you. Thank you very much. Chief Sawa, thank you, sir.
Then, sorry, additionally, there's depressed PRO segment. If you compare the TP segment to the PRO segment, you notice that it's actually depressed. It's below the isoelectric line. So aside the elevated ST segment, if you look very well, the TP segment is what we use as isoelectric line. You notice that the PRO segment is depressed compared to the line that we are supposed to use to compare the ST segment and then the TPR. So if you look very well on lead 1, 2, 3, and also on V4, V5, V6, also is also seen on others, but it's more prominent on 1, 2, 3, V4, V5, and V6. So the PRO segment is actually depressed if you look closely.
It's very clear, really. Thank you very much.
Thank you.
Yes,
Thank
and
you.
also this ECG is also demonstrating the spodic signs. which is the downsloping of the TP segment. So this is a comprehensive ECG showing all the signs of pericarditis.
Thank you, Chief Conte. So good.
And also, sir, we shouldn't forget AVR, with AVR in pericarditis. So will come out in MCQs.
So what about the AVR?
Everything we have said in is diffuse in every other date, but in AVR, the opposite occurs. So that will be depression of the ST segment on AVR and elevation of the PR.
Okay, okay.
Yes, thank you.
Thank you very much. Okay, so essentially here we have pericarditis. So in pericarditis, the first thing to start with is non-steroidal anti-inflammatory therapy, beyond which you can now start corticosteroid and then colchicine. So I think the plans to choose option C here, which is non-steroidal anti-inflammatory therapy is indicated. Thank you very much. Further comments or contributions? In absence of further comments, I think question 438. Which of the following statements about coarctation of the aorta is true? A, after successful repair, systemic hypertension frequently persists. Coarctation is more common in females. Chest pain and palpitation are common symptoms in older children and adults. Atrial septal defect is the most common associated cardiac findings. A mid-systolic murmur over the mid-anterior abdomen is common. Well, what I know very clearly in this option is that after successful repair, systemic hypertension frequently persists. I know that one for sure. The other associations, I think any other you can help with this, please. Thank you very much. Hello.
Hello. Thank you very much, Dr. Uzoke. I would just add that coarctation is commoner in males. I think same goes for PDA, if I recollect appropriately. Then the common syndromes with coarctation of the aorta, maybe bicuspid aortic valve, Turner syndrome can be seen in them. They can also have PDA, VSD. I think they've talked about abnormalities with the mitral valve and sometimes the dilatation of the aortic root in patients with coarctation of the aorta. So that knocks option B out. And option D, they have VSD and not ASD. So those are my contributions. Thank you.
Thank you very much.
Then I think option E, sorry. I think the murmur is the one that is heard in the back or something. Coarctation of the aorta murmur, I think you hear it at the back of the patient. So that rules out E.
Okay, thank you very much. Now, question 439. In absence of further contributions, I take 439. An 80-year-old man presents with syncope. During evaluation, a systolic murmur is auscultated and an echocardiogram is obtained. A continuous wave Doppler recording through the aortic valve is shown in figure 4.3. Which of the following statements about the disorder is not correct? Option A gradual decrease in exercise tolerance or dyspnea on exertion is the earliest manifestation. B, up to 50% of patients with this condition who describe typical angina do not have significant coronary artery obstruction. C, syncope commonly occur without significant change in systemic vascular tone. D, autopnea, paroxysmal nocturnal dyspnea, and pulmonary edema are late manifestations. Please, can you have a look at the figure 4.3, please? Okay. Thank you. Okay. That is the septal leaflet of the mitral valve pulse wave interrogation. And here we have something, I have the tracing below the line, which is approximately about 400. Oh, this is the velocity. Okay, is about 400. So so for the fact that this jet is below the line, means that it's a regurgitant jet. So we have a mitral regurgitation.
Can I comment? Can I comment? I think
You're welcome,
if you
sir.
look very well, this is it looks like a continuous wave Doppler, which is placed over the aortic valve, and the jet that we're seeing is actually the aortic valve, the flow across the aortic valve. And look at the volume. Look at the I think it's about 4.0 meter per second. If you look at the left upper part of that frame, I think it's about 4.0 meter per second. So this is actually the peak aortic systolic velocity, which is about 4.06 meter per second. Considering where the continuous wave was actually placed. So it's not, I don't think this is not a mitral regurgitation flow.
Wow.
It's even labeled though. See, AOV2
Yeah,
max
exactly.
is labeled.
Okay.
And
Okay.
aside the labeling, if you look at where even the continuous wave flow is actually placed, is actually the fifth chamber. This is like an apical 5-chamber user.
Okay. Okay. Apical 5 chambers, not apical 4 chambers.
No.
Okay. 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 All right. Okay, so the question here is, which of the following statements about this disorder is not correct? Now, from the disorder, it means that when you have up to 406 meters per second, you tend to think of aortic, I think aortic stenosis, right? Yes, aortic stenosis. So each of these things here are not correct. Going for A gradual decrease in exercise tolerance or dyspnea on exertion is the earliest manifestation. Cannot take that out in a hurry. B, up to 50% of patients with this condition who describe typical angina do not have significant coronary artery obstruction. That most likely is true. C, syncope commonly occurs without significant change in systemic vascular tone. That will likely be true. The apopnea, paroxysmal nocturnal dyspnea, and pulmonary edema are late manifestations. Backflow. That could be true. Is there any other option again? Can we have? Okay. Is that is okay? Gastrointestinal bleeding has been associated with this disorder. Well, I don't know. I can't imagine any association between aortic stenosis and gastrointestinal bleeding. If anybody has something
There is
otherwise to say.
hello.
Hello, sir. Go ahead, sir.
Yeah, there's an association between aortic stenosis and GI bleeding. There's something we call the Heidi's syndrome. So a case of GI bleeding that usually occurs in patients with aortic stenosis. Okay, yeah, you can see Adenjo has posted it on chat. Heidi's syndrome.
The Heidi's syndrome. All right.
Yeah, sorry. Let me just also add here. If you look at the pressure tracing across the aortic valve, there's two things that we should always pay attention to in the grading or classification of aortic stenosis. Always look at the AV max and the pressure gradient. The AV max of greater than or equals to 4 meters per second and pressure gradient of 40. So I just quickly look at using 440. The moment you are getting greater than or equals to 4, AV max 40, then you are most likely dealing with aortic stenosis, most likely the severe type. But again, you'll have to still look at the other parameters such as the aortic valve area. Around most reliably using the continuity equation to get that. I can't see that them giving us this, but the two parameters, the gradient and AV max, can also suffice to make that suspicion of aortic stenosis.
Thank you very much.
And also an addition, thank you, Dr. Sawa. And I think is the gradient, the pressure gradient that I just mentioned now. Those measurements are those are the things I think we need to answer this particular question, because it's possible to have stenosis. If it's mild, it might not be symptomatic. So if is the pressure gradient here that is indicating a severe aortic stenosis that gives out the answer in this question, really. Just like when we have a mitral stenosis, is the gradient that really makes patients symptomatic. So is the progression of illness, and is when the gradients across those valves are actually high. That's when the patient starts presenting with classic symptoms. So in these patients now, we will know that it's not likely for option C to be true at this level of severe aortic stenosis. If the velocity or the gradient was less than 2, for instance, the aortic valve might still be calcified, but the resistance across that pressure across that valve might not be high. So that, I think, is what we need to answer this particular question. Thank you.
Okay. So you're of the opinion that option C cannot be the answer, right?
Yes, C cannot be the answer at this gradient. This is severe stenosis here. Because it's greater than, like Dr. Sawa pointed out, velocity greater than 4. And also the main gradients greater than 40, severe stenosis.
Thank you, Alison. More contributions, please.
Okay, so I was just thinking aloud as regards is it the Hyde syndrome? You know, in aortic stenosis, what happens is that the stroke volume or the cardiac output is actually reduced. So basically, what happens is that blood is only supplied to the vital organs, that's to the brain, the kidneys, and to the heart. So the other organs are poorly perfused. I'm just thinking aloud, they're poorly perfused. So due to hypoperfusion to the GIT, ischemia, infarction, so that infected part will now be easily can be easily ruptured. So that can lead to a GI bleed. Now I'm just thinking probably that's how that can actually result in a patient with aortic stenosis. I'm just thinking aloud. I don't know if I'm right or not.
Well,
yeah, you may be right because it's angiodysplasia that leads to that
yes.
high. That center of high syndrome is angiodysplasia.
Okay, maybe if I can just make a contribution too on that. The head syndrome is actually a triad. There are 3 components in head syndrome. There must be aortic stenosis 1, 2 is the angiodysplasia that we talked about, and 3 it's a secondary von Willebrand dysfunction or factor deficiency. So those are the 3 triad that we need in H syndrome. So it's the combination of those 3 factors that brings about the anemia and the like. So the angiodysplasia, yes, like I've rightly said, is the commonest or is the pathogenesis of the GI bleeding that they see in them. It's actually a component I think we should just check up. Thank you.
Thank you very much.
Thank you, thank you.
Can you help us project the answer? Let us read the answer, please. If possible.
What have we chosen as the answer?
We've not been able to arrive at any answer.
No, the answer is C.
The answer is C.
Yes, I said C.
All right, thank you.
And it is because of those gradients and the like. So.
All right. Thank you so far. We're at 441. We're actually at, okay, let me see. All right, 439. Okay, thank you. The answer is C, as we had already stated. The Doppler record displays a symmetric systolic profile with an elevated transaortic valve systolic. Okay. Okay, so we should leave, we say the answer is correct, we should leave the reading, right? I should go to question 440, right? I go.
Yes.
Why not just read it?
Hello.
Hello.
Doctor, Siri, I think you should read it.
Okay.
Thank you.
Thank you very much. Could you please help us? So let's go to the answer. Thank you very much. The Doppler recording displays a symmetric systolic profile with an elevated transaortic valve systolic velocity of 4 meters per second, which corresponds to a peak instantaneous systolic gradient of 64 millimeters of mercury from the simplified Bernoulli equation, pressure gradient being equal to 4 multiplied the velocity raised to power 2 squared. Thus, these patients present with symptomatic aortic stenosis, angina pectoris, syncope and heart failure. Heart failure are the cardinal symptoms of this condition. The onset of symptoms in the patient with AS is an ominous sign. Natural history survival trends show that the time of death following symptom occurrence is approximately 5 years for patients with angina, 3 years for those with syncope, and 2 years for the patients with heart failure. Angina is present in approximately 2/3 of patients with critical AS. It arises in absence of significant coronary artery obstruction in up to half of patients, owing to both increased oxygen demand and impaired coronary vasodilatory reserve with microcirculatory dysfunction. Whereas the most common early symptoms in these patients with AS is a decrease in exercise tolerance or dyspnea on exertion due to reduced left ventricular compliance or the limited ability to increase cardiac output with exercise. Symptoms of advanced heart failure, that's autopnea, parotid nocturnal dyspnea, and pulmonary edema occur late in the course. Syncope in AS typically occurs with exertion and is due to systemic vasodilatation with reduced vascular tone in the setting of a fixed cardiac output. An association between calcific aortic stenosis and gastrointestinal hemorrhage, particularly due to angiodysplasia, has been observed, termed Hyde syndrome. Associated bleeding is thought to arise because of shear stress-induced platelet aggregation by the stenotic valve with reduction of high molecular weight multimass of von Willebrand factor and an increased number of proteolytic Can we go up a little, please? Can we go up a little further? Yes. Proteolytic fragments. This abnormality is correctable by aortic valve replacement. Thank you very much. Hyde syndrome, noted. Thank you, Chibolalekon. Can we move back to the question? Let me take the last one, please. Oh, thank you very much. All right. Thank you. Question number 440. A 28-year-old man presented to the emergency department because of severe chest pain and dyspnea after cocaine use. His medical history is notable for several years of intermittent cocaine use, alcohol abuse, and cigarette smoking. He has no other known cardiac risk factors. Which of the following statements about cocaine use and the cardiovascular system is not true? A, cocaine use increases the risk of myocardial infarction 24-fold in individual otherwise at low risk for MI. At least I know it increases the risk of MI. The risk of MI after cocaine is related to the amount ingested and the frequency of its use. I'm not sure of this one. Left ventricular systolic dysfunction can occur both acutely and after long-term cocaine use. That's certainly true. Next option, please. Mechanisms of cocaine-related myocardial ischemia and infarction include coronary artery vasoconstriction and enhanced platelet aggregation. That one is true. So let's go back to the other side of the question. This is out, but it is true. Okay, thank you very much. A is out because I'm certain it is true. Now my problem remains, the thing now remains between B and C. Let's go to C. Left ventricular systolic dysfunction can occur both acutely and after long-term cocaine use. Of course, acute left ventricular dysfunction, when it becomes chronic, can occur after a long time, can become a chronic left ventricular dysfunction. I think C is most likely correct. That means it is not correct. That means it is not the true answer here. The risk of MI after cocaine is related to the amount ingested and the frequency of its use. When cocaine goes in, it stimulates the. I think this B is most ambiguous. I'll stick with B. Thank you very much. More contributions and more contributions.
Okay.
Thank
Hello.
you. Yes, I can hear you.
Okay. Of course. I just want to talk about a patient I have. Is a young man, 27-year-old, took cocaine, and then he has LV dysfunction. What I'm trying to bring out is that I'm not sure whether the frequency of his use affects it. I think it's more related to the amount. I'm not sure, but that's what I think. He took a large dose and that happened. So that's just what I want to bring out there. But I don't know whether there are any other contributions. Thank you. And then they can have LV dysfunction both acutely and after a long time use. That's true.
That was good. More contributions, please.
I'm sorry, Dr. Alison. I always call it Alison. I find it difficult to pronounce a Yoruba name. Okay, that means it can actually, the left ventricular dysfunction can occur acutely if it is taken in a very high dose, right?
Yes, exactly.
Okay, thank you.
Adeyanju, why are you impersonating?
She's the one that
You
is
answer your name now. Yeah, then you tell her your name.
Yeah, please, if tell me. Yeah, Adeyanju.
Okay, thank you.
Yes. So B is the right option here, I think. Yeah.
Yeah, you're right. B should be. If you remember, Dr. Adeyanju, we have different case scenarios for these different options that are here. Even aside the patient you painted, the last patient I admitted with substance abuse that had severe chest pain that we're even thinking was aortic dissection. He was not taking, he was not used to taking exercise, just took the, what's the name that they called them? What did they, Shisha, no, what did he call it? And he just took it 3 days before presentation and he was not taking it before. So not necessarily for, just like you said, prolonged use. Might just be, you used it once and you are having a drastic acute reaction to it. And it's possible to have been taking it for a long time and still present also with symptoms. And just like he has said too, you could have both acute left ventricular dysfunction from it, and it will have chronic effects of the substance abuse. And this also is a form of Minoka. Thank you.
Thank you.
This
Then I
Minoka, sir.
that we should just like we remember for binge alcohol holiday syndrome. Maybe we should just take this one to like the binge use of all these hard substances can actually give LV dysfunction. Yeah.
Minoka is actually a new concept because people are really moving, don't only diagnose maybe ACS when you have like obstruction. It's possible to have non-obstructive forms So I think we should actually read about it. Came out in the last 1 year, and they're talking about it. We can't see. They talked about it at the last NCS too. So please let's
Maybe
just try and check it. There are different pathophysiologies and there are different types, like I've said. So this just reminded me that coronary spasm is also another pathophysiology. I've mentioned myocarditis, we've mentioned Takotsubo, we've mentioned SCAT, we've mentioned the microvascular affectation. That's the not the large coronary vessels now, but the distal ones that even angiography will not pick, and we pick all those ones through maybe other means like our OCTs and that's ultrasound of the vessels. So it's a new concept, and we have like 5 pathophysiologies. I think we've covered the 5 now.
I think maybe we'll make it as one topic for presentation. But the most classical thing with this is that you do PCR and there will not be any obstructions in the vessels. Thank you very much.
I remember for this to be no Kaineka.
That's what we are saying now, so that we are seeing questions in exam and we are remembering ourselves. Don't worry. We'll win by God's grace. Well done.
Amen. Amen. I think that's the end of that's 340. I don't know if the 341 is around. Thank you very much, everybody, for the support.
Yeah. Please, 441, Dr. Adebayo, I think Adebayo Ajayi, or if any other person is ready, we can just take 5 more questions and go and sleep, if it's possible. Oh, Dr. Conte, are you ready to attempt your part?
Okay, I think mine is towards the end of the 491, I think. Yeah.
Okay, so if we are all in agreement, we can do Dr. Conte's zone. The reason why I'm suggesting that is if the person to take 441 to 450 is not available, is either we take it together. If we take it together, it will take more time, or we just take somebody that is ready. So that's why I'm proposing that somebody that is ready should.
I think it's fine. Let's take them, Dr. Conte, so that we'll get explanations. Thank you.
Thank you.
Okay. Yes, 491. So a 70-year-old man with multiple myeloma presents with new biventricular heart failure. An apical 4-chamber view from a transthoracic echocardiography study is shown in figure 4.16. Which of the following statement about this case is true? Maybe we look at the echocardiography image and then look at the options. .16, okay. So this image is showing severe thickening of the walls of the ventricles. Okay, so both left ventricle and right ventricle, the walls are thickened. And also when you look at this apical view towards the basal part of the left ventricle, the lateral basal part of the left ventricle, you can see echolucent area between the myocardium and the pericardium. So you can see a small amount of pericardial effusion there. And you can also see it over the right ventricle as well, down towards the right atrium. So there is significant ventricular wall thickness with mild pericardial effusion. So usually when you see such a pattern, on echocardiography. Amyloidosis is one of the things that come to mind. Okay. And then usually, though it's not very clear in this picture, but you have what they describe as speckled appearance of the myocardium when you have amyloid deposit on the myocardium. Okay, so let's look at the options. And then remember, this
Sorry,
one, they've already...
Conte, before you go, before we leave the picture,
Yes.
maybe I should just make comments on it before you leave. Yes, greatly well described. I can't see the picture again. Okay, well described form. Yes, you said bilateral enlargements, the sparkling appearance, granular in nature. And I would also say that this is actually an apical 5. I don't know why they are calling it apical 4, because you can see the aortic valves too, which appeared
I can see a little bit of it.
it appears sclerotic. You see it appeared thickened a little, which is prominent. Then we'll appreciate that we have bilateral enlargement here. The right atrium, the left atrium are enlarged, and the ventricles, though hypertrophied, are not enlarged. You can see that the cavities appear small. So it's this thing that we describe as the rabbit hair appearance. It's also here. So we should note that the cavity is small. The right atrium is big. The left atrium is big. So bilateral enlargement, thickening of the ventricles here, biventricular, granular appearance, then the mild effusion. Yeah, thank you. Those are at least what we can see here on this image, although there are other features to look out for too in amyloidosis. So in case we see, the reason why I'm pointing it out, it might not be in these particular options, or it might, amyloidosis is something they bring out. So I heard they bring it out so often. So we should also know most of the other features, even if it's not present in this question. Thank you. Wow. Was I audible?
Yeah.
Okay, thank you.
All right. So the options. So the A option says this disease is caused by sarcomeric. So they say which of the following statements about this case is true? So this disease is caused by sarcomeric gene mutation encoding for beta myosin heavy chain. Okay, so this one, they've already told us the patient has multiple myeloma, which is an acquired condition. So that makes that one false. The ECG is likely to demonstrate criteria for LVH. This is an infiltrative disease, so you will actually see thickened wall with low voltage complexes. So that one, B, is also false. The most common cardiac presentation of this disorder is restrictive cardiomyopathy. This is true. In fact, what this echo is showing are typical features of restrictive cardiomyopathy with the bilateral enlargement and with the myeloma-associated amyloidosis. The common presentation is the restrictive cardiomyopathy form. The D is saying recurrent blood transfusion is a risk factor for this disorder. That is not correct. It's not a problem of transfusion. Yeah, if there are any contribution.
Thank you very much, Chief Conte. I would just say that D is not correct, but for hemochromatosis, and then that A will go for Ocon if they rephrase the question. Thank you.
All right, definitely. All right. So 492. It says the two-dimensional and M-mode echocardiogram image in figure 4.17 were recorded from an asymptomatic 24-year-old woman. Valvular regurgitation is absent by Doppler interrogation. Which of the following statement is true? So let's go to the image. 4.17. Is it? Okay, 4.17. All right. So you have a four-chamber view, but concentrating more on the left ventricle. And then underneath, there is a Doppler. There is an M-mode image. So let's look at the four-chamber view. So what you can see from the four-chamber view, just by 2D image, just looking at the image, the ventricle, the left ventricle and the left atria, they look a little bit dilated. But what is striking is that if you look at the posterior, you can see the posterior mitral leaflet is underneath the anterior mitral leaflet, and it is going below the mitral valve plane. So if you imagine a straight line from the hinge point of the mitral valve right across, you'll see that the posterior leaflet is going below that, which is what you look for a prolapse of the mitral valve. And then if we look at the M mode, so this is M mode usually from the parasternal long axis, sampling at the tips of the mitral valve leaflet. So what it is showing you is the opening and closing of the mitral valve. Okay, so they've put letters in the images. So the E is showing you the early filling of the ventricle, so that the early opening of the mitral valve. Okay, and then A is the opening that comes with atrial contraction to add, the final 25% of left ventricular filling. So the next point C to D, is supposed to be during systole. So this M pattern that you are seeing, the EA is in diastole because that's when the ventricles are filling. So point C to D is systole. Okay. So usually this one, the valve should be closed. Okay. So you expect a straight line across, and then before the M pattern repeats again. But what you see there is that from early in, from about mid-diastole, you see separation, okay? And there's sort of a U-shaped depression of the posterior leaflet. See, the posterior leaflet separates from the anterior, and you have a U-shaped depression. So that is typical M-mode finding when you have prolapse of the posterior mitral leaflet. That's the pattern that you see, okay? That U-shaped depression of the posterior leaflet in systole. Okay. All right. So we can go and look at the options.
Sorry, Dr. Conte, you were saying it's M mode at parasternal long axis view. I thought it was apical 4. The M mode. Hello, Dr. Conte.
Yes, I'm getting you.
No, I don't know if I heard well. You were saying this is M mode at parasternal long axis view.
Oh, sorry, there's a mistake. Yeah, it's apical long axis.
Okay, all right, thank you.
It's apical 4-chamber view, not parasternal long axis.
But sorry, Dr. Conte. Dr. Briggs, the upper image, the echo image you are seeing is the apical 4.
Yes.
The M mode image you are seeing down can only be gotten from a parasternal long axis view. That's when you put your this thing on the mitral valve. Yes, on the mitral valve.
Okay.
Not
Okay.
the pulse wave, no, not the pulse wave. The M mode, that line that you use for taxi to cut, just like you are doing mitral stenosis, you want to check. So this, you want to do left ventricular, you are using your M mode tracing for ejection fraction. So just the way you put it across the ventricle, you will put it at the tip of your mitral valve. You will get this tracing, and you'll be able to see the anterior mitral valve open at diastole, like he has explained, and close at systole. You also need this image view when you are looking for SAM in HCM. You need this same view when you are looking for your mitral stenosis. So there are so many things that we can use this view. Yes. So you actually measure mitral valve prolapse and diagnose that 2 millimeter from the midpoint on parasternal long axis view. But you can just appreciate it better on the apical 4 that we are showing, that is shown here rather. I'm not sure if you got that.
I got you.
Yeah, hello. I think I misheard what she was asking. All right, go ahead.
Yes, you didn't understand our question. Yeah. That was why our question was different from, yes.
I understand you now, because the M mode is actually used on parasternal long axis, while the EA ratio use Doppler, pulse Doppler, right?
Yes. Yeah. Yes.
My mind was on pulse Doppler using apical 4, but this is actually M mode.
No, this is M mode. Yes.
Long axis. Okay. Now I get you. Thank you so much.
Yeah. Okay. All right. So let's look at the options. Yeah. Okay. So there was a relatively young patient, 24-year-old, and they say no valvular, valvular regurgitation is absent. Okay. So it's like she has prolapse, but without regurgitation. So which of the following statement is true? Okay. A, the patient should undergo repeat echocardiography every 6 months to follow this condition. So this one basically would be an asymptomatic, mitral prolapse without any regurgitation. So you can repeat the echo for this particular patient every few years, except if they have a change in symptom or they start becoming symptomatic. Then you want to, do an echo when they have symptoms. But otherwise, if they are not symptomatic, it's every few years that you do the echo. B, she should receive antibiotic prophylaxis.
Sorry, Chief Country. How many years did you call it, sir?
No, they are not specific. They just say a few years. In a few years, it's not very specific. Okay. So, but what determines when you are going to do, because this one is asymptomatic, no regurgitation. Yeah. If they begin to get symptoms, then you must do an echo immediately. But if they are not having any symptoms, they stay a few years, so 2 to 3 years. You can do.
Okay, 2 to 3 years. Okay, thank you.
Yeah. Then B, she should receive antibiotic prophylaxis to prevent infective endocarditis prior to invasive dental procedure. So I think at some point we discussed the infective endocarditis guidelines, and mitral valve prolapse is not one of those conditions that are considered for prophylaxis for infective endocarditis. So generally, with mitral valve prolapse patients who are not symptomatic and don't have regurgitation, prophylaxis for endocarditis is not indicated. She's at increased risk of sudden death. That is also not true. Asymptomatic mitral valve prolapse is not a risk for sudden death. She's at increased risk of thromboembolism and requires chronic oral anticoagulation. This is also not true for this patient. You know, the only time you need probably anticoagulation is if they now develop regurgitation, marked dilatation of the atrium, and they have an arrhythmia. They have, for instance, atrial fibrillation or flutter, then you have to anticoagulate. Then that becomes a valvular AF or flutter. So, but at this stage, she doesn't need anticoagulation. Advanced age and male gender are risk factors for progression of this disorder and ultimate need for surgical intervention. So that is the true option. The interesting thing about this prolapse is that it is common in women, just like one of the other conditions we mentioned earlier. It is common in women, like we mentioned for what you call it, Takotsubo, that it is common in women, but when men have it, the prognosis is worse. So it's a similar thing with prolapse. Prolapse is common in women, but when men have it, they have worse outcome compared to the women. And of course, with advancing age, you know, the risk for the need for surgery increases. So here the answer is E. Any further contribution?
Sorry, Chief Conte, that A option, he said the correct answer is 2 months, right? To be followed up every 2 months, right?
No, not 2 months, years.
2
Every
years.
3 years, so 2 to 3 years.
Thank you.
Yeah. Okay. 493. 493, a 75-year-old woman presents to a physician with severe fatigue and intermittent cyanosis. Initial evaluation reveals that cyanosis had been present for approximately 1 year and occurred chiefly during mild to moderate exertion. Transthoracic echocardiography yielded images that were suboptimal. Therefore, transesophageal echocardiography was performed. Figure 4.18a shows the basal image from the TEE, and figure 4.18b shows an image obtained after injection of agitated saline into the right antecubital vein. Which of the statements about this patient and the echocardiographic image displayed is correct? So let's go to the image and then we come and look at the options. Okay, good. So the image is showing a esophageal echo. Although they've just cut it out just at the image, because usually one of the easy way to identify a transesophageal echo image is at the top right-hand corner of the image. You always see the angulation of the ultrasound being displayed. Okay, it forms like a semicircle sort of, and you see an indication of the angle at which the ultrasound beam is being emitted. So that's one of the giveaway for transesophageal image, but they've not captured that here. So this view is actually what is called the bicaval view. Okay, although in the image A, it is not showing very clearly the superior and inferior vena cava, but the view should actually show the. So if we're looking at figure A, it should show the superior vena cava on the bottom right side of the image, okay, and then the inferior vena cava on the left side, okay, and then the membrane you are seeing across, that is the interatrial membrane, and that cavity at the bottom is your right atrium, and then the cavity at the top is the left atrium. Okay, so from this one, from the interatrial membrane, you can see there is a defect in the interatrial membrane. Okay, so this is the A is the basal image, and then when you come to B, that is after agitated saline is injected. So when the activated saline is injected, you can appreciate from this image that it is coming from the right side of the image at the bottom. So in the image B, you can actually see a bit of the opening of the superior vena cava into the right atrium. Okay. And so that's the agitated saline filling the right atrium at the bottom. And then you can see some of the saline going through the defect that we saw in the basal image, going into the right atrium. Now, when you are doing TEE, you can only see this kind of vivid image with the contrast going through like that when you actually have pulmonary hypertension associated with a shunt. Okay, so it's like you are having a Simenga sort of, that the pressures in the right atrium are now greater than those in the left. That's the time you could see this dramatic, movement of the bubble across the membrane. So usually in people who have not developed Simenga's transformation, you will not see the bubbles going across like that, like a jet across like that. Sometimes you even have to apply pressure on the right side by compressing the abdomen after injecting to increase the pressure on the right side to allow the bubbles to move across. Okay, because under normal circumstances, people without increased pulmonary pressure, you expect a left to right shunt when you have intra-atrial defects. Okay, so this diagram is showing an intra-atrial defect, okay, in a patient with increased pulmonary pressure because of Simenga transformation. And the way the defect is showing here, this is typical of a secundum atrial septal defect. Now, if it were an ostium premium defect, this will not be the view to look at it. Okay, this bicaval view will not be the preferred view. So you'd want to do a 4-chamber view because premium is more a part of endocardial Cushing defect. Okay, so the upper part of the endocardial Cushing is not there. Okay, and most times when you see premium defect, they are combined with other forms of endocardial defects, even with a ventricular defect, sometimes complete endocardial Cushing defect. So this cannot be a premium defect. Now, the other thing that you should think about is the sinus venosus defect. A sinus venosus defect, what you'd see, you'd actually see, because when you have a sinus venosus defect, it most times come with anomalous connection of the pulmonary vein. Okay, and because the sinus venosus defect is high up in the septum, you can't see it in transthoracic view, and even in the transesophageal view, you can't see it in the bicaval. You can't see it on the membrane like this in the bicaval view. So what you see is at the connection of the superior vena cava, that's where you see a communication between the left atrium and the superior vena cava. So you see blood coming from the left atrium into the superior vena cava. Okay, so that would be a sinus venosus defect. So this one, when you are seeing it clearly on the membrane like this, it can only be a secundum atrial septal defect. All right. Okay, so now let's look at the questions. Yes. All right, so this 493, yes, good. So say which of the statements about this patient and the echocardiographic images displayed is correct? So A, the saline contrast image demonstrate left to right interatrial flow. Okay, so that is not correct. It's from right going to left, the flow that we saw. B, the image verify a sinus venosus atrial septal defect. So that is also not correct because that one would see a communication between the left atrium and the superior vena cava. And then C, an anomalous pulmonary vein is demonstrated, also not correct. And then D, in TTE, Doppler interrogation of the subcostal position is most useful for identifying this anomaly. Yeah, that is very correct. In the transthoracic view, once the patient has good images, when you go into the subcostal view, okay, looking at that's when you have the ultrasound beam going perpendicular to the interatrial septum, and you can see the full extent of the interatrial septum without echo fallout. So you can be able to put color flow and demonstrate flow across the septum and even do a bubble test from that position and also make a diagnosis of atrial septal defect. So this is the correct answer for this question. Any comments or clarification? Okay, then we move to question 494. Okay, I'll read from my device. 494, it says a 29-year-old man is referred by his family practitioner for evaluation of a heart murmur that was first had during childhood. He is asymptomatic. Part of his evaluation include an echocardiogram. An M-mode panel from that study is displayed in figure 4.19. Which of the statement about this case is correct? So let's look at the figure again. Figure 4.19. Okay, good. So we are back with another M mode. Okay. Yes. So this is a similar M mode to the other question that we did. So in the parasternal long axis view at the mitral valve leaflet tip. Okay, so displaying the excursion of the mitral valve. All right. So you remember the position. So after the flat portion in between, that is systole, the valve leaflet are closed. Okay. And then in diastole is when they are open, they separate. So you see that there is the E, okay, and then it comes down to form the A with the A part of the image. You can see there is sort of undulation of the image, or what looks like how would I put it now? So sort of back and forth movements, what you get from vibration, okay, on the image, all right? And then it closes again. The same thing happened the next one. When it opens, after the E, between the E and the A, you see that vibratory movement sort of the valve leaflet, okay? So this is actually like the phenomenon of Austin Flint murmur seen in M mode. Okay, if you remember, Austin Flint murmur is when you have aortic regurgitation, and during diastole, the regurgitant jet impinges on the anterior leaflet of the mitral valve during diastole, and it can mimic the murmur of mitral stenosis, a diastolic rumbling murmur. So that is what is demonstrated in M mode. Okay, so during that, from mid diastole now to the end of diastole, you see that vibration. Okay, so this is what is shown. So from this question, a young man, you know, that has had that murmur since birth coming. So likely it's someone with an aortic valve pathology, most likely a bicuspid aortic valve with aortic regurgitation that is now producing this vibration on the anterior mitral leaflet. Okay. All right. So with that said, we can go and look at the options. So 494. So so they say which of the statements about this case is correct. So we are looking for the correct answer. A vegetation is present on the anterior leaflet of the mitral valve. So that is not true. A bicuspid aortic valve is a recognized cause of this finding. That is correct, as we've mentioned. This disorder is commonly associated with rheumatoid arthritis. Not at all. This finding contributes to dynamic left ventricular outflow tract obstruction. So that is not correct. If I can just mention, when you have dynamic left ventricular outflow tract obstruction, that is what you see in hypertrophic cardiomyopathy, and it produces what you call SAM, systolic anterior motion of the mitral leaflet. So what you see in SAM is that because in systole, when the valves close, they should be around the center, you know, of the strip, the image that you see when you do the M mode. So when the valve closes in systole, they should be around the center, thereabout. But in SAM, you'll see it going towards the septum. It will go up in systole. Okay, it will open nicely in diastole, you get the M pattern. But in systole, that flat line from C to D in the initial image that we saw, you'll see it moving upwards towards the septum. Then that is what you'll see in SAM. So that is not what we are seeing here. So that makes D false. So the correct answer here is B. Any further questions or clarifications?
Okay, sorry. I just want to add, in
Yes.
aortic regurgitation, you can actually hear 2 or 3 murmurs. So you can hear 2 diastolic murmur, 1 systolic murmur. The first diastolic murmur is the normal aortic regurgitation decrescendo diastolic murmur that you hear at the Eps point.
Yeah.
Then the second one, the second diastolic murmur is the Austin Flint that you talked about. Then they said the third one, plus or minus, is another systolic murmur. That because most times when there's severe aortic regurgitation, there may be a stenosis coexisting with it. So it's possible that you're having AR and you're hearing 3 different murmurs. That's just an addition.
Okay. Thank you. Okay. Any other comments?
Please continue, sir. Yes, at 495.
Okay.
Okay.
Sorry, should I continue, or we want to stop at 495?
Well, if the class says, I'm looking at the time too. If the class, if people are feeling sleepy, we'll continue. But if not, let's stop at 495.
Okay, well, we'll take 495.
Let's stop at 495.
Okay.
Yeah, so let's take 495. So it says a 34-year-old woman who is originally from India presents with dyspnea and is found to be in atrial fibrillation. Following conversion to normal sinus rhythm, an echocardiographic study is obtained. Figure 4.20 display a continuous wave Doppler recording through the mitral valve. Which of the statements about this condition is not correct? So let's go back to the image before we come look at the options. Okay. So 4.20, yeah. Okay, so this one is showing continuous wave Doppler across the mitral valve, right? So this one, first of all, the way you're seeing the intensity of the Doppler signal, continuous wave signal, okay, telling you there is high velocity flow across the mitral valve, okay, and you can see the peak velocity, they are quoted as 2 meters per second. Okay, so that is high velocity, that high flow for the mitral inflow. You know, mitral inflow normally is passive. So having velocity up to 2 meters per second is high. So usually it should be less than 1.5. It should not be up to 1.5 meters per second. And yeah, I think so. Basically with this one, you can either trace the entire tracing there of the mitral inflow, which will give you an estimate of the mitral valve area. And also you can do the pressure half time, okay, from the peak to, you take that slope from the peak to where the first wave, where you have the, how do you call it, the notch, okay, and you can use that also to estimate the area. All right, and then also from 2D, you can use planimetry to estimate the area in this sort of patient. So we are seeing a tracing of mitral stenosis. All right. So let's look at what the options are asking about. All right, 495. Good. So they're saying which of the statement about this condition is not correct. So we're looking for the wrong one. A two-dimensional echocardiography would likely demonstrate thickening of the valve leaflet and chordae apparatus. But remember, it's a 34, relatively young, from a third world country. So rheumatic heart disease, very high, first differential. So, and thickening of the mitral valve leaflet and chordae, one of the classical findings that you get. B, the peak velocity of transmitral flow in this case is decreased. No, as we've said from the picture, it is increased, it's not decreased. So B cannot be true. C, in early diastole, the posterior leaflet of the mitral valve commonly moves in an anterior direction in patients with this condition. Okay, so this is something that they've observed on echocardiography, that people who have severe stenosis, okay, because in rheumatic valve, you know, the disease starts from the tips, okay? Commissural fusion is what happened, and then thickening progress to involve the rest of the valvular apparatus. So the tips of the valve are very, very much restricted, okay? So when you have this condition, the posterior mitral leaflet, because the tips are restricted, you know, during diastole, filling of the ventricle. When the restricted tips fail to move, then the whole valvular apparatus tend to move anteriorly during diastole. So that one has been observed on echocardiography in people who have severe stenosis due to rheumatic valve disease. D, the mitral orifice size can often be determined by Doppler pressure half-time measurement. Yes, that is true, of course, as we mentioned. And then E, elevation of the pulmonary artery systolic pressure as estimated by tricuspid regurgitant jet would likely be present in this patient. That is also very true because you have increased right atrial pressure, and that pressure backtrack into the pulmonary circulation and cause your raised pulmonary pressures. Okay, so the false statement here is B. So the velocity is not decreased, but it is increased. Yeah, any contribution or questions? Hello, is everybody asleep?
Nah.
Yeah.
Not at all, Chief Conte. We're all awake. So.
Oh, okay.
Talk for yourself, Dr. Cyril. Talk for yourself.
Thank God you heard it. It means you're awake too.
That's a good one. I think this is a good point to end for tonight.
Yes, I agree. Thank you so much. Thank you.